Welcome to this episode of the Dry Eye and Ocular Surface Disease section of the Clinical Podcast Series, brought to you by the American Academy of Optometry Foundation. Today's episode is Meibomian gland dysfunction, one disease, heterogeneity among phenotypes. My name is Kaleb Abbott. I'm an optometrist and assistant professor at the University of Colorado School of Medicine, and I'm joined with Dr. Cory Lappin, who's in the process of starting a dry eye and ocular surface disease practice called the Dry Eye Center of Ohio. That's going to be located in Cincinnati, Ohio. We're excited to have him join the podcast today and to discuss the heterogeneity amongst clinical features of meibomian gland dysfunction. We will discuss if all MGD is the same and what clinical features perhaps are the most significant. Thanks for joining us, Cory.
Thank you.
Can you start by explaining what this study was actually exploring?
Yes. So basically what the study was looking at was specific features of MGD and how they relate to signs and symptoms, specifically tear production, corneal staining, and inflammation. And the exact features that they looked at for MGD were four classical features, which were meibomian gland plugging, gland dropout, meibum quality, and also eyelid vascularity.
Yeah, I love that they included eyelid vascularity here. This is something that's starting to become a bigger and bigger topic in ocular surface disease. So how was the study actually conducted?
So they used 40 individuals who all had the signs of MGD that we mentioned. So again, the plugging, the vascularity, meibum quality, and they looked at meibum dropout. And then they looked at symptoms. They used several questionnaires. Then they also did the ocular surface evaluation, which looked at staining. They did Schirmer's for tear production. And then what they did is they also collected tear samples from the Schirmer strip, and they analyzed them for 23 proteins that corresponded to inflammatory.
And what did the study end up finding?
So what they actually found was really, really interesting. So when they looked at each feature, starting with gland plugging, which is, probably one of the most obvious for us, they actually didn't find any correlation between differences in staining and tear production, which was surprising because for all the other parameters for eyelid vascularity, meibum quality, and meibomian gland dropout, they actually did find more staining and lower tear production. Now, specifically though, when they looked at those inflammatory markers that we had talked about, it was really only eyelid vascularity that was really correlated to that significant increase in inflammation, which was really, really an interesting thing. They also found that age was only really correlated with everything but gland plugging again. So really gland plugging was interestingly not very correlated with anything there compared to the other ones. Then they also found some other things like patients when they looked at their health history and medications that those who were using antihistamines had more eyelid vascularity. So just some of the interesting things they found as well there.
Yeah, so eyelid vascularity was the number one factor linked with tear film inflammation as measured through 6 different types of tear cytokines. Did that surprise you, and what are your thoughts on that?
Not really at all, actually, kind of like we said, because what we're understanding about vascularity right now, and we know when we say vascularity, and they mention it once in the paper, basically talking about telangiectasia, the spidery kind of abnormal vessels, and we know that they're prone to basically to leaking inflammatory factors. That's the thing. They're not necessarily normal vascularization. And
Sure.
we know 2 of the conditions that are really commonly associated with this. Number one is ocular rosacea. That's a big one. And then Demodex blepharitis, we often see with this too, but there's probably some overlap between ocular rosacea and Demodex blepharitis as well. But
Sure.
to me, it actually makes sense. And I often think of inflammation and the side of dry eye because we always talk about the vicious cycle, right? That inflammation's there. So I always like to think about inflammation as either being primary or secondary, and I like to think of MGD the same way because MGD, can be caused by different factors. So I think both inflammation and MGD are separate but related entities. So when I think of lid vascularization, I often think of ocular rosacea. So in that case, the inflammation is coming from the ocular rosacea, and that can lead to MGD. So
Sure.
in a case like that, mentally, because that's how I like to keep track of it, I would say that's primary inflammation and secondary MGD, because the inflammation came first and then it caused that. Whereas some of the other findings here that were less related to inflammation or more classical of obstructive MGD, where you have the gland dropout and the poor meibum quality. In that case, that's where you have more of the primary MGD, where the meibomian glands start to be dysfunctional, and then that leads to inflammation afterwards. So that's where you'd have a primary MGD and a secondary inflammation. So to me, this study very much kind of goes with how I like to think about things clinically. So really kind of fit into that paradigm.
So I think you kind of gave your answer to this already, but circling back to the title of the paper, is Meibomian gland dysfunction a single disease? What do you think?
I don't think so. And I think that's starting to become more established. There's not really, set criteria for what is MGD, and there's not necessarily a consensus definition. But I think most people would agree that kind of like dry eye itself, it's multifactorial. One thing I think we should start doing more is putting descriptors onto MGD. Instead of just calling it MGD, and I think this paper kind of speaks to it, we should call it ocular rosacea-associated MGD or Demodex blepharitis-associated MGD, because that's just going to help us know exactly what the nature of the MGD that we're dealing with is, because really MGD is an umbrella term, is what I would say it is for any dysfunction of the meibomian.
Yeah, totally agree. Well, what are the take-home points for our listeners?
I think the biggest thing is, instead of just looking at MGD now, I think this paper gives a great framework for some features to look at. It's not too hard. Take a look at these different features, and if you happen to see, hey, they have MGD plus this. So is it MGD plus poor quality meibum? Is it MGD plus lid vascularity? And I think that's where this becomes clinically relevant, is we all know, I think it's becoming more common knowledge now, is that the old standby of warm compresses is not necessarily what we want to do for all MGD patients. Classically, we would think about doing that because the idea is, let's, warm up the meibum, get it out there. But this paper really shows that if you see MGD and you also see lid vascularity, that's probably not what you want to do, because you're more likely to dilate those vessels and get more inflammation. So maybe even a cold compress might be better for these patients. So really, I would say when you see MGD, look for some of these features to kind of really find the specific type, the subset of MGD you're dealing with. And that's just going to help you figure out what you want to do for treatment.
Well, special thanks to Dr. Cory Lappin for joining us today on the Clinical Podcast Series. See you at the next episode.